The other thing, obviously, psychiatric care. We don't need to touch a patient. All you need to do is talk, evaluate, watch. The one sort of caveat that may not work is sometimes with little kids, there's interactive play that you do as a part of a therapist where you just can't really do that online. But with adolescents, they're actually showing that you have a much better interaction, a much more clear interaction with adolescents because they're used to a computer screen. They're used to video conferencing. They're used to playing games online. And by removing that kind of closed, strange environment, they tend to open up. Let's get through that. Maybe a lot of, on your question, or your question may stem around, okay, well, physicians, how do they charge for this? How do they get reimbursed? Well, Georgia was one of the first states. In 2005, they mandated that all private insurers within the state of Georgia must reimburse at 100% the rate as if that patient had come into the office and you're staring at them face to face. So they're required to pay. Medicare, Medicaid is a little bit different because it's a federal program and they dictate kind of the rules to the states, or at least provide the necessary structure. They require that the patient be in a facility of some sort that can already charge Medicare, Medicaid. So a school, a rural health center, a hospital, a doctor's office. Typically, that's what they do. The other common question, other than the legal aspect, is, well, do people even want this? The fact is, yes, 50%, and this was 2 years ago. Actually, no. Yeah, PricewaterhouseCoopers, 50% of patients would prefer or would be willing to use this sort of video conferencing technology to see their physician rather than driving in. I would say that from our own internal surveys, once we find out that about 75% of patients have never heard of telemedicine, and once they hear about it, we're seeing ranges which shocked me, upwards of 80 to 85% want to be a part of it. And in that subset, there are probably 15 to 20% that are even willing to pay out of pocket if their insurance wouldn't cover it, and would be willing to buy equipment to make sure that they could be seen that way within reason. So it's really that, what we're seeing, and this is, it's a small sample, it's probably about 500 or 600 people, and it's been shocking for the executives. We didn't expect that sort of a response. So it's powerful. That's what they want. That's what consumers want. And I'll bet in here, let me ask you that, if you had the opportunity, rather than, for minor things or just a follow-up, would you prefer to go see your doctor in person, or would you prefer to be able to be at home or be at work and see them in the exact same capacity?
Choice B.
Choice B. Well, how about show of hands, choice B? Depends on the condition, that's fair. Okay, but obviously most of you, we're looking at about 90%. So you fit, you're in there. Especially, I can imagine in Atlanta, and just trying to get through traffic to get to your doctor is much more preferable to be at home. The other question is, well, this is pretty safe. This seems kind of quack. They can't touch me. How do they really examine me? What we found is that the most common medical diagnoses that were made were otitis media, dermatitis, pharyngitis, and upper respiratory tract infections. Now, this was done with a telemedicine cart where they could actually use fingers and do those sorts of things. But it wasn't chest pain. It wasn't my gallbladder's erupting. My appendix is about to drop out. It was nothing like that. It was simple stuff. The most common mental health are ADD, anxiety disorders, depression, and conduct disorder. Very, very easily treated remotely. We've also found that telemedicine, and this is the studies, there's even a peer-reviewed journal that does nothing but talk about new telemedicine studies, and overwhelmingly we're seeing that patients not only are safe, but the treatment, because it's faster and because you get expert clinicians to places where they weren't before, we get better treatment. For diabetes, families are saying that when they use telemedicine, and this was actually at a school, that it prevented them just simply going to the emergency room. And I don't know about you, have any of you ever tried to call a doctor after hours? Okay. And have they said, I can't really tell over the phone, you're probably just going to have to go to an urgent care center or an ER. Is that kind of what you get? That's exactly it. So that's what happens. People, and that's where this probably comes from, that 80%, I'm going to have to go to the ER. spend an hour, 2, 6 hours, 12 hours of grading, waiting to get in to be seen for something minor because my physician couldn't see me. 98% of the exams didn't require follow-up, and 92% said they'd love to use it again. Powerful stuff. Also, the other question we need to ask is, well, how do the practitioners feel? They feel that they felt confident in they really understood what was going on, and they felt that they had the correct diagnosis, which is exactly what we want. I threw this slide up there. I talked about Georgia, but there are 13 states currently, or 14 states that have, 15 states, excuse me, that have passed legislation that require insurers to pay. There are another 17 at least that are on the docket for this year. And we've got, and Medicare, all 50 states, they'll do it as long as a person's in a rural facility. And with Medicaid, last I checked, it was about 45 states that would pay for it. So that's essentially it. Questions? Go ahead.
Do you think the statistic that you had where 98% of the consults didn't require follow-up, is that inherent in the fact that you're not going to be using the service for a serious condition?
Yeah, most absolutely. If you're not going to do it, somebody who's having a cardiac event, right. You're not going to do that by telemedicine, but that's changing as well. Not so much obviously in the home or in a clinic, but now we've got rural ERs that are staffed by family doctors who have no idea about emergency medicine. And we've got emergency physicians who are connecting by telemedicine essentially to be that brain in the room saying, we need an IV, we need to start epi, let's hang that normal saline, continue chest compressions, get the ultrasound in here, let's see if we can get, all that can be done. And so that statistic may change. Go ahead.
I work for VA, and telehealth is, we call it VA, Veterans Health Administration.
Oh yeah,
Telehealth
huge
is
support.
huge, and we started like 2 years ago. And we use the digital
Stethoscopes?
and we have that card, and patients, veterans, they can go to the rural CBOC, that is a clinic, and the specialty, wherever they are, they connect to them.
Yeah, that's
great.
Veterans is fantastic, and
Yeah.
I'll add this, with the Veterans Administration, they've done a couple of really interesting things. They decentralized how you get care if you're a veteran. So rather than having to go to these hospitals with these doctors' offices, they've said, let's open up clinics everywhere, and let's pull away a lot of that infrastructure there and put it out in communities where the veterans are. And then secondly, with telemedicine, just this past year, they passed a new resolution, or I don't know what to say, but a new rule, in that not only will they pay for the telemedicine visit, but they'll also pay for the patient's copay if they use telemedicine. So if they go see the doctor, they actually have to pay more out of pocket than if they went and sat in front of a telemedicine suite. And that kind of fits almost actually with Australia. Last year passed a law that patients, if they are seen by telemedicine, not only do the doctors get paid, but they actually get a bonus if they see them by telemedicine as opposed to seeing them in their own office.
Just a comment. I've never ever been to a doctor's office where I haven't had my temperature taken and my blood pressure taken and so forth. So in this model, unless you're going to a center that has that peripheral support, are you saying that that's no longer necessary in an office visit? It's being done
No,
necessarily?
I would say, well, I'd answer with a two-part sort of answer to this. First of all, this is an adjunct sort of thing. If you're doing it into the home, this is an adjunct. This is not something that you're going to replace your visits with.
So then my second part is then, that goes with that, of the 50% or 90% of people saying that this is a great idea, are they assuming that they can do it from their home, or are you saying, well, you might have to go to a center where these services are provided? Because in that case, it's not quite
yeah, exactly. No, in the actual survey, it says if it's appropriate. Not, this is, and at the very beginning it says this is not for everything, this is for minor follow-ups or medication refills, those sorts of things. But you're exactly right. So it's an adjunct, it's not going to work for everything. Typically where we're seeing it used is we've got a diabetic who's out of control, who needs more frequent sort of counseling, and let's see what your sugars have been running, How have you been doing with your medication? Let me see you inject yourself. I want to make sure you're doing that right. So it's not needed to have the vital signs. The other way is for cholesterol management. I mean, you talk about diet and those sorts of things, or rash. You know, I've got some strange rash. Let me see that. The other thing I would say about when you walk into a physician's office and you always get your blood pressure taken, you always get your blood pressure taken. Most of the time, most of the clinicians, physicians, if they went into that room and had to do it themselves, they would. And the reason that they do is meaningful use as part of the EMR. I don't know if it's second or third, but I think you have to have 90% of the patients you have come in, you have to get their vital signs. So they're being graded on that. So they're automatically going to get the blood pressure whether you need it or not. Whether you are 5 years old and have had no history, they're going to get a blood pressure and temperature on you.
Well, speaking to that, as this telemedicine advances and mobile technology advances, what would keep, and specifically with the vital signs and whatnot, or even testing? If I'm sick, I may have strep throat. Going out in public is going to expose other people to it. What would keep some of those testing devices from being mobilized to where, now they already have something where you can check your blood pressure on your phone.
Mm-hmm.
And what if they had like a strep test that you could plug into the port and then it would transmit the results? Do you see those types of things being integrated with telemedicine where the doctor really can be in one central location and maybe I could be I could administer my own vital signs?
Oh yeah, most definitely. And that has purely to do with the technology phase, and I'll say that's something from a Smart House Calls perspective, that's our plan. That's our strategic plan, is that we want to get to a point where there's sort of an app with a couple of little peripherals that you can plug in that would work in that way. And in fact, I read a really interesting paper about a year ago that they're figuring that our touch screens on our phones are actually much more sensitive than we think, and they are working to develop the software that can actually detect pathogens from a blood sample that you put right on your phone, and just right on the screen. And I wrote an article for Advanced for Nurse Practitioners that I titled it, you can probably find it somewhere, but would you pee on your phone, please? So sorry to be somewhat crude, but yeah, so that they're talking about that. Ultimately, what is the smartphone? It's a computer, it's a processor, and why do you need a glucose monitor that's got a processor in it? Why don't you have a little thing you just hook in and do it, or Bluetooth technology that connects right to your phone and sends it off? Yeah.
It almost seems like it would be cheaper. Looking at the price of a visit to go see your primary care physician, it seems like insurance companies might even be able to subsidize these peripherals to get to the patient because the reduced compensation that the provider may get, even though they're seeing more people, could be passed on in the sense of, here, we'll provide these things to you. You go to, you agree to go to the doctor less for your follow-up and maintenance type things.
Yeah, and there's some of that they're already doing. I think the jury's still out because there is that fear that people will overuse it. Though when I've spoken to at least 4 C-level people within 4 different insurance carriers, they've all said that they are welcoming telehealth technology because it gets the treatment there earlier. I thought we were going to become successful, and all of a sudden they were going to start denying claims, and we've seen the opposite. There hasn't been that issue. And that's because it's cheaper to treat someone in their own home, especially when you consider, and I'm waiting for Medicare to figure this out. I think some of them have, but it costs $150, $200 to get a Medicare van to go pick up someone, or a Medicaid van to go pick up someone and take them to the doctor's office, sit there and wait an hour, 2 hours, and then drive them back, or drive somewhere else, take care of someone else, and that patient sits there for 4 hours, and then take them back home. Much cheaper to say, let's just send a medical assistant out there with a telehealth thing, and let's go ahead and take care of them. They can draw the blood, they can do blood pressure, vital signs, they can handle all the equipment, I can listen to heart sounds. They can do EKGs remotely, you can do, if you had to, you could do ultrasounds remotely, all that's possible, because ultimately all we're using is a processor and a computer, and you just hook everything to it.
This is a two-part question. I know you said in your presentation that, you know, ACOs and medical homes, it would be really advantageous for them to use this technology. Is that primarily who you're marketing to, like insurers and managed care organizations, or?
We've been primarily marketing right to the providers, to larger institutions or people that coalesce providers, so independent physicians associations, hospitals that recently started working with HCA Hospital. And one of their goals is to hire, I think, 30 or 40,000 physicians over the next 5 years. So that's where our marketing has been. The ACOs, there's some interest there, but as far as a strategic standpoint, we want to be a part of what they're doing because there's ways to help. But ultimately, they're only going to buy, you know, they may have 100 physicians, but they'll probably only buy 2 or 3 licenses.
And as far as from the patient's end, so if you're going to the physicians and the providers, what's needed from the patients to be able, like, do they have to have software or like?
With Smart House Calls, there's no software to download. It's all, the software is purely on our server. So all they have to do, have you ever used WebEx? Okay, well, if anybody's ever used WebEx, it's something like that. With WebEx, the video conferencing platform, you get an email with a link, and you join through that link. Now, WebEx